Okay, everybody, we'll go ahead and get started. Tonight's webinar is the Introduction to Manual Osteoperforation and High Frequency Vibration. My name is Dr. Eddie Sauer, and I live in Amarillo, Texas, and practice in Amarillo, Texas. And tonight we're going to talk just a little bit about how that actually works and how it actually works in my own practice. So, of course, the first things we've got to get out there is number one, I'm not employed by any dental company. I don't own any stock, securities, or interest in any dental company. There's no family member that is employed or owns stock in any interest in any company. And I have consulted or evaluated products for Propel, Align, Sirona, and Patterson Dental. And so here's this disclaimer. I've been compensated in the past for consulting or evaluating products for the sponsors, including Propel Orthodontics. And for my participation in this event, I've received an honorarium from Propel. The opinions expressed tonight are my views and may not necessarily reflect the views or policies of the sponsor. The materials provided for education use and not used for advertising or product endorsement. This presentation has been approved for continuing education credits, and no photos, video, audio recordings are permitted during the event. So this is a little bit about me. I graduated from Baylor in 1987. My practice has mainly been around restorative implant and family dentistry. I have been using clear aligners in my practice for the past 15 years and have been speaking for several different people. And a lot of my practice is surrounded by going through the Dawson Academy of Pankey. So let's first we're going to look at the science behind what actually goes on manual osteoperforation. And so what ends up happening is, what normally happens is whenever you have a bone injury, it will cause the normal response is going to be an inflammatory response. And in that inflammatory cycle, there's cytokines that are produced, which actually all of those things lead to prostaglandin production, which actually then leads into the stimulation of osteoclasts and osteoblasts, and it actually increases the rate of the bone remodeling, and it decreases the bone density, in essence making it a little bit softer. And so the way that actually ends up working is whenever you place a force on a tooth, on that pressure side, you're going to get a vascular constriction, and it's actually going to cause basically kind of cell death. And on the tension side of it, it's actually going to cross some tension, actually cause the cells to proliferate. You're going to turn on the osteoblast, and you're going to also have fiber production. And so what ends up happening is you get resorption on the pressure side, and the osteoclasts, they end up, what I'm pointing at right here, they end up remodeling the bone and move it out of the way, while on the tension side of it, we actually see the bone actually being stimulated and growing, which then allows the tooth to actually be moved in the direction of where the osteoclasts are. Now then, if there's a heavy force, and you get undermining and you do it too much, you can actually get resorption, and you can get the pressure side actually causes a vascular obstruction, which is the one thing that we don't want to see end up doing. So now then, when we get that frontal resorption on the pressure side and we get the osteoclast moving in, then we end up getting the bone remodeling. So what ends up happening is we have our blood vessels, the monocytes flow out, they go through the stimulation phase, and we actually turn on the osteoclast and the osteoblast. And so you go through a phase of resorption, reversion, formation, and then mineralization. And that's actually how we get the teeth to actually move through. So there was a New York University clinical study, and what they did in there was they had 20 patients, And what they ended up doing was they used a handheld appliance designed by Propel, and they did the micro-osseous perforations in between the interproximals of the teeth. And what they observed which was very important, was that they got a 2.3-fold increase in the velocity of the canine movement. And through that, even patients only had mild discomfort at the spot of the mop. And so now then, that gave us the ability to realize that there was a lot that could actually be done. And so here's the pictures that actually kind of support what went on. So they, on the right side, they used it as the basis, and on the left side is where they did the micro-osseous perforations. And then you can see an A was at the time when they were done, and B was 24 hours post-treatment, and you can't hardly even tell where there was any of the osseous perforations made. And in the C level, you can see what's happened whenever you compare the static side to the side that actually had the micro-osseous perforations, and you can see how far that the canine actually retracted. So there was a significant movement in just a 28-day period as opposed to the standardized side. So there's a lot of different ways that you can actually accelerate orthodontics. And one of those ways is there's a low frequency vibration. And whenever you're using the low frequency vibration, it will help facilitate some minor anterior movements. And actually, whenever you're doing that, your aligner, your clear aligner, needs to be removed during the treatment. And that device also requires for you to wear it for a 20-minute period a day. And the cost to the patient is about $500 per device, and it relies on patient's compliance also. And there's also a high frequency vibrational device, and the idea behind it is it's going to help ensure that you get really good aligner seating. And the aligners have to be in place for this to actually work. It's also rechargeable. The nice thing about the high frequency vibration is it only is required for 5 minutes a day, and it's a little bit less expensive, under $400 per device, and it relies on patient compliance also. So the other side of that is going to be the osseous perforation. And so the typical one is the corticotomy, or it's been called Orthodontics. It's the most invasive. You actually flap the tissue, you go in and you decorticate interproximally. There's a pretty high cost for the patient, and there's also some pretty significant pain that actually goes on with this at the same time. And it requires some pretty good training to go with it. Then the next way is to use the piezo surgery. It's a little bit less invasive. You still have to lay a flap or tunnel. It still has recovery time, and there's still a pretty high cost to the patient, and the clinician's got to be trained extensively also. And then when we go to the other way of doing the osseous perforations, there's the micro osseous perforation. And that, whenever we're talking about doing that, it's a micro invasive. There's no patient recovery time. There's little to no cost to the patient, and the training for the clinician is very minimal. And so it works really well. So whenever we talk about doing the manual osteoperforation, there are different devices that are out there, and the three main devices are, there's the single-use device, there's a reusable handle, which you actually put a new tip in each time that you use it, and then there's the power driver, which actually is the most comfortable to be able to use, because it is, instead of you having to manually be turning to get the device to penetrate through the tissue and into the cortical plate, basically you have a power driver that's doing that for you. So the benefits of us doing the manual osteoperforation is for the patient, it's minimally invasive. The technique is performed chairside in just a few minutes. You can use it with aligners, or you can even use it with traditional braces. There's really no patient recovery time needed. The doctor controls it. There's no patient compliance that's needed. It really saves time, less office visit. It means less time off of school and work. And for us in our practice, it provides a cutting edge technology that we can provide for our patients, and it increases the treatment acceptance because the patients are going to be more likely to accept it with a faster treatment time. Today, patients, they're looking for faster treatment times, and they would like to have everything done yesterday. And this will help you attract those patients that do want to move through that. And it's a premium treatment, and it keeps your patients from being in their treatment for such a long period of time. And now then they burn out after a period of time. So as far as doing the procedure is actually really pretty easy. It's 3 simple steps. You're going to evaluate the treatment area, palpate the tissue, look at the x-rays, make for sure that you don't have roots that are going to be too close together that you can't have access to be able to do the perforation with. Then the next thing that we always have our patients do is they'll rinse with chlorhexidine 2 times for 1 minute each. And then we'll go and we'll anesthetize and do the acceleration. And actually the way that we do that in our practice is whenever we are delivering the clear aligners and we're placing the attachments, is the first thing that will happen will be we'll place the topical, let the topical sit for 4 minutes, then we'll rinse that topical completely off. We typically use an isolite to retract the lips. And you'll see a picture of one here in a minute, and I'll make for sure that I'll let you know what that is if you haven't seen isolite before. And then we dry everything off. And so for the next 15 minutes or so, while the attachments are being placed, that topical has its chance to make its effect onto the tissue, so that we are not actually losing time or actually spending any extra time at all waiting for this to actually occur. So then once the attachments have been placed, and then I can come into the room and talk to the patient, we've got everything set going. It typically doesn't even take 3 or 4 minutes to go around to do the micro-osseous perforations and have everything done. So it really doesn't add to any time in our practice at all. So in my experience, most of my patients require 1, maybe 2 treatments. And in a very, very rare situation will I ever even do 3 treatments. And I will tell you that in my personal practice, most of the time, 1 treatment will actually, an average case has about 25 aligners, and that will actually be more than enough. Typically, what I end up seeing is those movements that are a little bit more difficult. A lot of that movement has been occurring early in the case, and as we finish out the case, the movements become more minor. And in a lot of my cases, I've actually seen just 1 treatment at the beginning of the case actually is very effective. And then you'll do 2 to 3 of these micro-osseous perforations are recommended in between the teeth, on the mesial and on the distal of each tooth. And the big thing that we notice is that we know for a fact is that the studies have shown is that the osteoclastic response is 6 to 10 millimeters around that treatment. So it extends that in either way. So whenever it has an additive effect, whenever you start to orthodontically move that tooth and increase the inflammatory response, it is just an additive effect. So if I do have some moderate or difficult movements, then those I'm going to probably add a couple of perforations extra around those to help make for sure that that bone density has been decreased and that the ability to move that tooth has increased. Typically, whenever you're going through, the anterior teeth is going to be about 3 millimeters and the posterior will be about 5 to 7 millimeters. If you're going to do palatally, that's typically going to be about a 7 millimeter to get through the tissue and just to get through that cortical plate. In my own practice, I rarely, if ever, do I actually use the palatal perforations. The osteoclastic effects are going to peak in 24 hours, and they're going to remain effective for over at least 10 to 12 weeks. And sometimes if you've got a lot of difficult movements that are being made, then you may be repeating it in 10 to 12 weeks if you feel like that it's necessary. So where I perforate is going to be, you can either perforate buccally or lingually. Typically, I'm going to use the buccal approach. It's the simplest, it's the easiest to access. It's really the easiest to make for sure that we get them comfortable with using our topical. And so it just kind of depends upon each one of those teeth. You can see here that between that premolar and molar that they've got a 3-point pattern, and then between the two molars, they've got a 3-point up and down pattern that has been used to make that work. So how I perforate, the perforation, if I'm doing and I typically don't use this one anymore, is it has 3 different depth settings on the manual. It's got a 3 millimeter, 5 millimeter, and a 7 millimeter. And typically you're going to do that. 3 millimeter is going to be needed on the maxillary and the lower canines. And some patients may need 5 to 7 millimeters around in the mandibular molar, you can see here from the chart. Really what I end up doing now at this point in time is you can feel as it is going through the tissue, and whenever you grab a hold of the bone and you just penetrate that bone, you can back out, and that's been extremely effective for me. So my perforation patterns, where they say it's possible you want to do 2 to 3 manual perforations. A lot of my cases, unless the only time that I'm using the 2 to 3 manual perforations is typically if I've got a moderate or a difficult movement. In all of those other cases where I really, and that's a lot of those cases, you really are not going to have a lot of moderate or severe movements. On those cases, I'm just doing a single perforation in the interproximal area between those teeth. So you can see right here, this is typically what it kind of looks like. That is the manual perforator, the single use that you can see over there on the left-hand side. And it also has the guide on those that lets you set that guide at 3, 5, or 7 millimeters. Okay, so what you're seeing here is this is the example of the Optigate that's in this area. So it's kind of like a rubber dam. It just holds the lips back and out of the way, makes everything really clear and simple. And you can see on this case that we did just one interproximally between each one of those teeth, and that would be effective even for this case. And here it is with the Optigate taken off and taking the pictures just a couple of minutes later. And you can see how on the top and on the bottom, how the perforations were done. So in the single-use device, you set your depth at 3, 5, or 7 millimeters. You rotate it clockwise while applying gentle pressure, and then you check the engagement with a light tug back. And then you rotate it counterclockwise to remove. If you're using the removable handle, you put the tip in from the sterilized packaging, and then you actually go through just exactly the same way. Now that whenever we're using the power driver, basically what ends up happening is you will set your RPM typically about, it'll be at the high position, which is 45 RPMs, and then you set your torque at 15 Newton centimeter, and that is typically going to be enough to be able to let you get the appropriate depth through that you need. Then you want to make for sure that your tip is 90 degrees to the point of contact so that it makes it nice and quick. And then you press the start-stop button, and then you just reverse the direction when you get through. Now, this is going to be one of the critical things about post-treatment, and actually, we talk to our patients about this whenever we're taking them through a clear aligner therapy anyway, is that the number one thing is that we are expecting inflammation to occur to help us make the movement occur. So we actually, during this period of time when they're going through aligner therapy, is that we ask for them not to take any NSAIDs, not to be taking Aleve or ibuprofen or Advil, that if they have any pain or problems, then they do their best to see if they can control that with Tylenol. And that's usually the best thing to do. That way they're not blocking the prostaglandin, the cytokines, and actually potentially slowing down the treatment that they need to have done. So in the high frequency vibrational device, it is actually used to help seat the aligners with a 5-minute daily wear time. And so what ends up happening, you have the mouthpiece, you have the oscillator, which is in the middle, and then you have a wall adapter and charging cable, which is in the bottom. So for delivery of it, it's really pretty easy. You charge the device, you put the two together. If you're using that, then you'll assign a specific patient ID, and then the patient connects the mouthpiece to the vibrational device and confirm that they can feel the vibration and that it's stable. You press the white switch on until it's activated, and then you let them just bite down on that for 5 minutes, and it automatically shuts off. And it will show you exactly that it's working or whether it's not working by the blue light that blinks. And it's got simple software so that if you're wanting to keep up with patient compliance, you can keep up with the patient compliance. The one thing that I will say that I have used it with is also, as I've had some patients, when we talk about compliant patients, that maybe we have gotten them all the way into their final retainers, and maybe they haven't worn their final retainer quite like they should. Matter of fact, I just didn't get the pictures for it. But I had a patient come in last week, and she has not been wearing her retainers like she should have been wearing them. And so what we had about 1.5 millimeters of clearance all across the lower anteriors. They weren't fitting back into the tray. And so right there, we assume that that's going to be a pretty difficult situation. And maybe we might actually have to restart that case or do something because they're already beginning to relapse. So we gave her the high frequency vibrational device and had her use it for 5 minutes twice a day is what I ended up having her do. 5 minutes for twice a day. And she came back in actually this morning before I left the office. And she actually had it all the way closed back down. It was back into place in a 7-day period of time. That one actually even really kind of surprised me because she's actually 48 years old, and she had only been wearing them sparingly over the past 6 months. And so there was a significant amount of movement, but lo and behold, she came in today and actually the aligners were all the way back down in place. Her retainers were. And so, now then she's a little bit more, would we say, compliant to make for sure she's wearing them so that they don't move. The best part about this is actually it also decreases her using the vibrational device, actually also decreases the post-op pain that's occurred from wearing those and making that kind of a movement. She said that she relatively had little or no pain after the first day. So it proved really good. So what we'll do now is we'll go in and we'll look at a few clinical cases that I've got of using the mirco-osteoperforations. So I call Phil my poster child. So Phil's 35. He had a class 1. He had a constricted arch form, had significant posterior collapse. His occlusion was pretty destructive. And if you take a look, he's got some wear on those laterals that are in crossbite. So whenever we had his treatment plan set up, Phil had 21 aligners. We started with the placing the attachments and the micro-osseous perforations, and he was a 7-day change out. And he did this in 4.5 months, and the treatment was completed with 21 aligners. And so you can see exactly where he went from. On the bottom left is where he started, and on the bottom right is where he finished. And Phil's was a great case. He was extremely excited by the results that he had. And so then I've also got the other end of the spectrum. So John is a 71-year-old man. He is a pharmacist in town. And so he had lots of work that really needed to be done. And so we suggested that the way that we could best make for sure that this work was, that the dental work that he needed to have done would be protected, would be if we move the teeth into the right position. And so he really didn't want to have a lot of time spent with this part of the deal. So we used the micro-osseous perforations. He had 30 aligners, which would have been a 15-month case, especially the fact that he was 71. There would be no way that we'd consider making that a shorter case. But actually, when it was 30 aligners and we used the micro-osseous perforation, we actually only had to do one mop application, and he was actually done in 7.5 months. And then we have started his restorative aspects. And so we're about halfway through his restorative at this point in time. We placed an implant up there in where we're missing the bicuspid, and have started restoring the other teeth that are broken down, those amalgams and the other things. And so it proved to be very successful for us. This is Rhodey, and she's 56, kind of the typical patient that had a 4-by extraction case. They come in and they've got a lot of TMD related headaches. And so the first thing that we needed to do was make for sure that we established a good CR. So she's a physician. She really didn't have a lot of time or a lot of patience for going through this case slowly. So it turns out that all we needed was 14 aligners to get her into a good position. So that would be typically 7 months. And so we were on we put her on a 7-day aligner change, and she was through in 3 months and 1 week. No refinement. Her TMD symptoms, they resolved within 2 aligners. And whenever we got to the end, instead of the bimanual manipulation, 1.5 hour kind of result that you would usually have to do if you're going to do a solid equilibration for them with TMJ problems, her equilibration was basically just a 15-minute resolution, because we had already established well her centric relation. So this is Kelly. So Kelly is 54, and so she has a class 2 with excessive overjet. She had an omega-shaped arch, you can see. She has a large diastema between number 8 and number 9. So on her case, we really felt like if we had have tried to restore that case without doing something, number one, that would make those teeth look extremely large. And then also number 2, we would have left her with a pretty significant occlusal problem. So her treatment plan came back with 23 aligners. So we did 23 aligners. So we did the micro-osseous perforation, and her treatment turned out in 5.5 months. And it was completed with 23 aligners and no refinement. So that's one of the things that I kind of want you to kind of begin to get out of this is a lot of the studies are showing that 50% of cases that are being done with clear aligner therapy, there's going to be some form of refinement when you get to the end of it. And so far, you'll see from these cases is that that's one of the other things that ends up happening with this micro-osseous perforation is it makes the cases more predictable, and and it reduces the number of refinements. Matter of fact, I seldom do, whenever I'm using the micro-osseous perforation, seldom do I have refinements. So this was Ginger. So Ginger's 62, and she also has an omega-shaped arch. She's got some excessive overjet. And we started on her treatment. She became impatient in the middle of her treatment, and she wanted it to go faster. So at that point in time, we provided her the micro-osseous perforation option. And so she had 22 aligners, and it was going to be 11 months. So 4 months using the micro-osseous perforation. The treatment was completed with 22 aligners and no refinement. And she was actually able to be a 5-day change out on hers. So this is Gene. And if we take a look at Gene, he was class 1. He had a V-shaped arch form, and he had significant posterior collapse. If you'll take a look at his lower, his mandibular occlusal pictures, and that occlusion was being extremely destructive. He had lost several teeth and ended up having to have implants. So we took him through to get his occlusion better established, to make it much more protective. His treatment plan was 21 aligners, which that would have been 10.5 months on a normal 14-day change out. His actual treatment time was only 4.5 months. We only needed 1 micro-osseous perforation. And again, there was no refinement. So this is Kimberly. So Kimberly came to me, she's 22. We had been treating her with TMJ splint therapy. She had been through ortho before. She had relapse. She was a half-step class 2. Her maxillary first molars were rotated mesially, so she had an slight omega-shaped arch. She had slight anterior crowding, a kind of a class 2 div 2, and this should actually be really quick and easy. Our biggest problem with her was one of our biggest problems that you see whenever you're taking somebody that they decide that they're going to do this, and that is getting them to be compliant. So what ends up happening is we started out with 13 aligners. She was wearing them kind of haphazardly. She kind of disappeared actually for a little while. So she comes back in. She thinks that she's going to be serious about it again. And so we rescan her. And this time she's got 16 aligners instead of 13. And she's still on a 14-day change out. And again, she's not wearing them, and she is also beginning to have the burnout that's occurring. So we scanned her one more time, and it was 14 aligners, and we used the micro-osseous perforation, and we followed her really close and found out on her that we could do a 5-day change out. And whenever we got it reduced that she could move through those on a 5-day change out, she actually was willing to stick the time out. And so whenever you've got 14 aligners in 5 days, that's basically 70 days. So her last time through was just right at 2 months. And that was a time frame that she was really kind of more willing to tolerate. So this was Melanie. This one's a really interesting case. So she's 34. She's got post-ortho relapse. She obviously has some form of a noxious habit. You can see on the upper right side. She never would really tell me what was going on there or what she had done in the past for that to end up happening. She's got an awful lot of recession. She's got a lot of problems with some perio that was also going along. So we got her perio under control. And then we put her through, once we knew that that was under control, we put her through clear aligner therapy. And her case turned out that she was going to be 15 aligners. So the first time we went, the first half, we did this without any micro-osseous perforation, and we didn't quite get everything that we wanted. So then what ends up happening is we go back in and say, we really need to do this to finish it out. And she doesn't know whether she's willing to finish it out or not. So we offer the micro-osseous perforation option. And then we did a 5-day change out, and in 2 months she was through. And the one thing that we learned at that point in time was the $500 that we were charging at that point in time seemed to be an issue for a lot of the patients, and they really didn't want to pay an upcharge for doing that. And so we had to figure out exactly what we needed to do to our fee schedule to restructure it. And I'll talk about that at the end on what we ended up doing. So this is Paul. So Paul's 50. He's class 1. He's got a reverse swallow issue. He's edge to edge in the anterior. He's got a big old thick tongue that you can see in a couple of those pictures up there. So what we ended up doing was we knew that if we got those teeth back into the right position and we hold and we've got a good retention that we've got planned out in the future, that we can be really pretty fortunate. And it'll be very successful. So whenever we go through his treatment plan, he had 28 aligners, and we used the micro-osseous perforation. So the first 14 aligners had a 10-day change out. He wanted to get finished quicker. We did the micro-osseous perforations. He moved to a 5-day change out. And so he had a total that he was only in at 6.5 months, as opposed to what would have been a 14-month trial with it. And his retention is holding really well. So those are my cases with the micro-osseous perforation, but now then we'll also take a look at using high frequency vibration. And I've got several cases where I've used it either solely or I've used it in combination with the MOPS to make a successful case. So this is John. So he is probably my test case. He's my poster child for using the vibrational device. He was class 1. He had a lot of spacing on the mandibular anteriors. But it looked like he kind of had a class 2 div 2 on the maxillary anteriors. And he already is having some TMD issues because he's been in a nighttime bruxism splint, and he's had headaches. So whenever we went through his plan, he had 30 aligners to bring everything back into place and to bring the lower anteriors, close the spaces up, and to create the space for the upper anteriors. So we had 30 aligners, and we used the V-Pro 5 only on him. So 6 months of using the V-Pro 5 for 7-day change until aligner 13. And then when we hit aligner 13, we had done a majority of the movement that needed to occur. And we changed it for a 5-day change until the end. So when his treatment was completed, he didn't have a refinement either. There was very minor equilibration, and his TMD symptoms were also resolved on about aligner number 6 or 7. So all of this has allowed us to be able to really successfully treat our TMD patients. This is another one of our TMD patients. This is Jerry. He's 37. So he had a class 1 omega-shaped arch. His lower anterior is hyper-erupted. He had traumatic occlusion on 10 to the degree that basically whenever you take a look at where 22 is and where 10 was, he actually lost that tooth. And so he had a bridge up in that point. He had an early reciprocating click in both of his joints. He had morning headaches, and he had a nighttime splint. So what we ended up doing was his case was a little bit more difficult to get us exactly where we needed to go, especially with those lower cuspids and the intrusive movements that we needed on 23 through 26. So with using the aligners, we went through the first time using MOP, and went through 24 aligners. And that was 4 months long, and he was on a 5-day change. And so then we had some refinements that we needed to do. And so we rescanned him, and instead of doing another round with the mop, we used the V Pro 5. And on the V Pro 5, we also did a 7-day change out on that part of it, and it worked really great. So when we take a look at his final, so the last picture shows on the left-hand side is the start. The right-hand side is when we rescanned him and did the refinement on his case. And then here, I went the wrong way. Sorry about that. And so here is his final. Minor equilibration, everything is stable, no headaches. Everything turned out really, really well on him. So one of the last things that we'll kind of end up talking about is using it for a restorative case. And I alluded to the one that we're still in the middle of on the top, John, that was 71 years old. But I've got a case here that we'll kind of walk our way through for you to see also. So this case is Paula, and she's 55. So Paula was post-ortho 4-by extraction. And so she didn't. The reason we're calling them hyper-erupted lower incisors is if you'll take a look at them, they have worn down significantly from the wear of being the way that her bite had been trapped over all of these years. And so as they erupted, you could tell if you look on the bottom left-hand picture that the teeth have actually erupted as they have worn. So her treatment plan was basically this. So she came in and she said, Eddie, and we're friends. And she said, I look like the Wicked Witch of the East. After all of these years, after they extracted her bicuspids and then they retracted everything and pulled it back in, she basically, her face was no longer had the right kind of profile. They had actually pulled the maxillary teeth way back in too much and gave her somewhat of a concave profile. And so she said, what can we do? Is there anything we can do at all? And the only thing that I had to offer her was, okay, maybe we can create a little space, do some expansion, create some space on the upper interiors, and then we can push the lower anteriors back into the right position, and then maybe we can restore those teeth and give her part of her profile back. So here's the way that Paula presented. And you can tell from her profile picture that she really had lost out an awful lot on her, on what had occurred in her over the years. So whenever we get her moved through, we've created some space in between on the top, and we've intruded those lower teeth on the bottom. And so this is where we end up getting her to the point. And the other thing that was occurring at this point in time was her oldest son was getting married, and he was getting married in about 6 months. So we had 6 months to do this. And so we used the micro-osseous perforations, and the micro-osseous perforations then allowed us to get her through in 19 weeks, which is basically 1 week short of 5 months, and then go back in and make the restorations. And so these are the day that we placed the restorations. And it restored her profile somewhat. And now then she's able to maintain, and we've been able to keep her from having any further wear occurring on her teeth. And so that's one of the ways that it's allowed us to make a complex case. In her case, really, we would have needed to have potentially have waxed that case up, tried to open her bite. Everything would have required a crown on it for her case to have been successful. And this would have been impossible to have been able to have gotten done in the period of time that she needed to have done before her son's wedding. And this allowed her to have a great result by the time her son got married. Matter of fact, I believe we placed the restorations about a week and a half before the wedding actually occurred. So now then we come down to the last part of this, and this last part is how do we make it profitable? And so what you've heard me tell you from earlier is that whenever we first started using micro-osseous perforations 4 years ago, we would charge an additional fee, and that works for some practices. And we were charging an upcharge of $500 to do the micro-osseous perforations. And we personally, in my practice, that was kind of a hit or miss deal. And so it was hard for us to be able to convince our patients to go ahead and to spend that extra money to make that occur in a faster rate. As you could tell by looking at several of my cases, or 3 of them, I believe, is how many that I have in here, that we get partially into treatment. They already begin to grow weary of wearing the aligners and the treatment that they've got ahead of them. And so they say, okay, I'm ready to start talking about that. And so so that happened for some of our patients. But then the real reality is we began to sit down and just take a look at it for what it was. Exactly what did micro-osseous perforations do for us? Well, one of the first things that micro-osseous perforations did for us is, if you'll remember those cases we've talked about, is basically, with the exception of Jerry's case, that we used the B-Pro 5 for the second half of his case, we would not have any refinements that needed to be done to those cases, or additional aligners that needed to be made to finish the case out. So the first thing that ended up happening was, wait, this is way more predictable for us, and therefore that predictable would be very profitable. So whenever we look at it, so let's take a typical clear aligner case with 25 aligners. And to make things easy, we're going to say that case fee is $5,000. I believe across the U.S. right now, based on statistics, the average case fee is $5,800, and it varies from portion of country to the portion of country. So the next thing that we'll talk about is how often do you have your patients come back in? Are they coming back in on a monthly basis? Are they coming in on a 6-week basis? Or are they coming in every 2 months? Some of the studies that I've read have shown that typically general dentists will do a 6-week recall, and turns out that a majority of orthodontists actually do an 8-week recall. And so it might actually be as many cases that they've done orthodontically, whether it's brackets and wires or it's clear aligners, they're seeing their patients on an every 8-week. So in other words, every 2 months, they're having their patients come back in for their recall. Is that if they've got this pattern down and they're being successful in their practices, maybe that might be something that we might want to also consider in our practice. But based upon a 6-week recall, here's what we found out. Our delivery appointment would average about an hour, or we would schedule an hour, and that would be for us to put on the attachments, to go through, to do any IPR if we were starting IPR, talking with our patients about everything, explaining to them what's about to happen, getting everything done. So that would take about an hour. What we did find out was, whenever we started using micro-osseous perforations, was we didn't lose any time if we would start by going in and putting our topical in, letting it set for 4 minutes, rinse it all really good, placing our Optigate, and then setting all the attachments on, so that by the time we were through with the setting on the attachments, the topical had its opportunity to work very, very well. And so I could just come in and within just a couple of minutes be able to do the micro-osseous perforations. So on a 6-week recall, you have the delivery appointment, and then we had 9 follow-up appointments. In other words, every time they came in, we would give them their next aligner plus 2. So that would be a 14-day changeout on a normal 6-week recall. There would be 9 follow-up appointments, and those appointments would take about 15 minutes to get the room set up, get the patient in, tear the room down, get it set up for the next patient. So whenever you do 9 follow-up appointments, that's about 2 hours. Then the next appointment is going to be our D button. In other words, where we take off all the attachments, where we scan them, take a new set of pictures, and that was scheduled for about an hour for us to go through all of that. Now, here's the deal. More than 50% of the time, we were rescanning them for additional aligners is what actually was ended up happening. So whenever we did an average case of additional aligners was typically about 10 more aligners was what was happening. So then they would come back in another 3 weeks, and then we'd do delivering the additional aligners, and that would be a 30-minute appointment. Then we would have 2 follow-up appointments. So whenever we would get into that point, we would actually extend our treatment out, give them a larger number of trays. So in other words, we'd give them 5 trays because they would typically be able to go through those trays on a quicker basis. So we've got 2 follow-up appointments for 30 minutes. Then you go back through, you do the D button, you scan them, etc. It's another hour appointment, equilibrate them, get everything all into position, and then you will see them 2 weeks later for their retainer delivery, and that's 30 minutes. So whenever we looked at that, that was 5.5 hours that was actually being spent on a case. And so the after case fee, in other words, so we would take out the fee to pay for our liner case, which was about $1,800. That after case monetary value of that case was $3,200. So if you take that $3,200 and divide it by 5.5 hours, your return, your productivity is about $580 an hour. Now, what happens is what happens if our case fee was exactly the same, whether we charged for our micro-osseous perforation device or whether we didn't. So in this case, we're going to not charge for our micro-osseous perforation device. So this is the way that it looks if we have a 6-week recall with micro-osseous perforation. So we still have the same delivery appointment, a 1-hour appointment. But now then the difference is we only have 4 follow-up appointments, because now then on a 6-week recall, we're sending them home with twice as many aligners. So they're going home with 6 aligners every time. So now then there's only 4 follow-up appointments. So now then we've basically cut an hour out of our chair time that we've been spending with our patient. So then we go back in, we debutton, we scan, we equilibrate, we do that. That's going to take an hour. But the interesting thing is, guess what? Almost all the time, we no longer have any follow-up additional aligner appointments. So we get to stop at that point. So we take our scan, we have our retainers made, we deliver them. So that's a 30-minute appointment. So now then we only have 3.5 hours into this. So whenever we look at that, now then our after case fee is going to be, so it's about $125 depending upon the number of perforators that you buy. So that you're going to say that your after case fee is, you've got $3,075. So your productivity on 3.5 hours, look at the difference. So whenever we began to look at the difference on that, we began to go, wait. This is actually, we really don't need to charge the patients the extra. We didn't feel like that we were going to have an extra charge for the patient for that fee, because our productivity in our office was significantly higher, almost right at $300 an hour higher by just using the micro-osseous perforations. So needless to say, almost all of our cases currently now have we use micro-osseous perforation on almost all of our cases. And there's some cases that we also, as you would see before, that not only are they a 7-day change out, we're actually at a 5-day change out on several of the cases, based upon how those aligners are fitting and how they're showing. So this is what we've seen has been an effective way for us to be very productive in our practice and provide our patients with a low-cost fee for it. So that has been probably one of the best ways that we have looked at it. Now then, if you choose to go with an 8-week change out, you actually will see your productivity be just a little bit higher. There's not that much of a difference, but you'll be well over $900 an hour if you're doing the 8-week recall with the micro-osseous perforation. So what we have found out is that it has been a very successful, very predictable part of our practice. And we have really enjoyed the outcomes. Patients have raved for us. And so it's a really good addition for you to make into your practice. And so with that, I'll take any questions that you may have, and thank you. So there was a question. We were told patients should wear the aligners when using Accelident. Is this opinion or just incorrect? You know what? That was originally the way that it was structured, and I'm not for sure. That may have actually changed. So that may be the case, and they may be wearing them now. And then also, does the handpiece have the same 3, 5, 7 millimeter setting? No, sir. That one does not have that setting. Here's what I will tell you, though, is that whenever I'm doing that, you can feel as it goes through the tissue, and just whenever it grabs a hold of the bone, then you can feel that it, just as soon as you get through that bone, that's where you stop. And that's kind of the way that we have done it. I hope that answers the question. Okay, any further questions? Okay, well, I want to thank you for attending, and I hope you guys have a great evening.